Hello, everyone. My name is Yuz Yusof. I'm a consultant rheumatologist from Leeds, United Kingdom. I'm reporting for Room Now live from Vienna to cover the Eular 2024 Congress. Today, I would like to talk about JAK inhibitor. As we all are aware, JAK inhibition treatment has revolutionized therapy for various autoimmune rheumatic diseases, including rheumatoid arthritis. However, this strategy has become under scrutiny over the last couple of years since the publication of the oral surveillance clinical trial data. In this oral surveillance data, they found that there was increased risk of malignancy and also major cardiovascular events in patients treated with tofacitinib compared to TNF inhibitors. Therefore, the regulatory have issued a warning to be careful in using a JAK inhibitor, particularly in those above 50 years old of age and also with multiple comorbidities. One other aspect as well is pertaining to infection. The data from the randomized control trials as well as the long-term extension studies did show some increased risk of opportunistic infection as well as herpes zoster. So does this data reflect in the observational study? JAKPOT is one of the largest collaboration of registries, which involve 14 registries in the Europe and also Canada. So in this study, the main aim was to compare the infection risk and also herpes zoster risk between patients treated on JAK inhibitors versus TNF inhibitors and also versus other mode of action. So other mode of actions including rituximab, tocilizumab, abatacept, and etc. This presentation, the abstract number was OP0092. In this study, a large number of patients were involved, were over 50,000 treatment starters that were analyzed. Looking at the key results, there was no increased risk of any infection or severe infection between patients treated with JAK inhibitor versus TNF. Any serious infection rate was quoted as 9 out of 100 patient years, whereas TNF is 7 out of 100 patient years. To me, this sound still a little bit low for a real world, and this sometimes what you might expect with the observational registry data, because there potentially could be some reporting bias as well that's not been captured. In terms of other comparison, those treated with the other mode of action had a higher rate of any infection and serious infection compared to the TNF inhibitors. Also, it's important to let you know there were some baseline characteristic differences, not a lot, but there were two that I could detect. One were due to the disease duration. So the TNF inhibitors group had much less, had less disease duration compared to the TNF and other mode of action, and consequently, in terms of biologic naive, so there were more proportion in the TNF group compared to the JAK. So this could potentially also influence the infection outcome. And another important key here was regarding to the herpes zoster rate. And in this real world data, it showed that the incidence ratio were 2 times more likely in the JAK inhibitor groups compared to the TNF, whereas there was no difference between the other mode of action versus TNF. So what this data showed that in the real world, there was no difference in terms of risk of infection. However, there was increased risk in terms of herpes zoster. And how this may impact our clinical practice. So I think we need to think of some measures to reduce infection-related risk, not just in JAK inhibitors treatment, but also in other biological treatment. We can counsel patients to help with other modifiable risk factors, such as to stop smoking and to live an active life and some exercises, but also can also trying to help manage their comorbidities better, such as diabetes and hypertension, for example. And importantly, with regards to the zoster risk for the JAK inhibition group, we also want to advocate vaccination, like shingles vaccination, in order to minimize the risk of activation. And certainly this depends on what has been done in other healthcare services. For example, in the UK, we can only administer the shingle vaccination in patients with autoimmune diseases who are 50 years old or older. So I hope you found this summary useful for your clinical practice. And follow me and Room Now for more coverage of the Congress content. Bye-bye.